Good morning, everyone. Can you hear me?
Yes, sir.
Yes, sir.
Yes, sir.
Okay. Slide is visible or not?
Yes, sir.
Yes, sir.
Yes, sir.
Uh, okay. So in the last class, we talked about that thyroid gland. Okay. So thyroid gland, it is producing or secreting two important hormones. Thyroxine hormone, which is also known as T4. Another one is triiodothyronine, also known as T3. Okay, so these are the two important thyroid hormones. Okay, as you know, these two thyroid hormones, they are influencing, we can say, virtually all cells of the body. So their main function is to increase the basal metabolic rate, or in short, BMR, to increase the BMR. And thyroid hormone gland is also producing another hormone that is calcitonin, okay, which is important for the metabolism of calcium, okay. And as I have already told you in the last class, that calcitonin will be discussed along with this parathyroid gland, okay, or parathyroid hormone, okay, in the next endocrine gland, okay. So today, our topic is regulation of thyroid hormone secretion. Okay, how thyroid hormone concentration is regulated. Okay, in short, we have already discussed this one also when we talk about the anterior pituitary gland. Anterior pituitary gland is producing the TSH, thyroid stimulating hormone, TSH. Okay, how it regulates the thyroid hormone also. In short, I have already told you. Okay, so today we will be discussing this one in more detail. Okay, so what is our first point? To maintain normal levels of metabolic activity in the body, precisely the right amount of thyroid hormone must be secreted at all times. So we know that metabolic activity, okay, is maintained by these T3 and T4 hormones. Okay, they increase the BMR. Okay, so right amount, as I told you, that optimum amount, that means it will be in a range. Okay, minimal range and maximal, minimal level and maximal level will be there. So within that range, thyroid hormone concentration should be maintained. Otherwise, if it is too much, there will be problem. If it is too low, again, below the minimal level, again, another problem will be there. Okay, so thyroid gland should secrete this optimal amount of thyroid hormone to maintain normal metabolic activity of the body. Okay, so you already know this one. To achieve this, specific feedback mechanism operate through the hypothalamus and anterior pituitary gland. Okay, to control the rate of thyroid secretion. From the hypothalamus, we know that TRH is released, which stimulates the release of TSH from the anterior pituitary gland. And TSH, it will act on the thyroid hormone to increase the secretion of T3 and T4. Okay, so these three organs, they are related: hypothalamus, anterior pituitary gland, and thyroid gland. They are all interrelated. Okay, regarding the secretion of the thyroid hormones. Okay, so these mechanisms are as follows. Okay, so there are so many important points here. Number one is TSH increases thyroid secretion. Thyroid secretion means T3 and T4 secretion. Okay, thyroid hormone secretion. TSH, you already know that it stimulates the cells of the thyroid follicular cells, and they are increasing the secretion of the TSH. Sorry, thyroid hormones. Okay, so TSH increases the secretion of T4 and T3 by the thyroid gland. Okay, how this is done? Okay, let's see. Point number one, TSH increases the proteolysis of the thyroglobulin. Okay, or we can say breakdown of the T3 and T4 from the thyroglobulin. Okay, so this you already know how thyroid hormone is synthesized, T3 and T4, how they are synthesized inside the thyroglobulin that we have already discussed. Okay, so let us see just here in this diagram. let's say this the whole structure. Let's say this is the thyroid cell, thyroid follicular cell, and here the colloid part of the that follicle is there, and here circulatory system will be there. That means it will be secreted into the bloodstream. Okay, so this is a thyroid cell, and you know that there is synthesis of the thyroid hormones T3 and T4. Okay, that is a combination of tyrosine and oxidized form of iodine. All these things we have already discussed. So here, this green in color, okay, this is thyroglobulin. So inside the thyroglobulin, the T3 and T4, they are stored after their synthesis inside here. And you see here also MIT. MIT means monoiodotyrosine. DIT means diiodotyrosine. MIT is containing one molecule of iodine. DIT is containing two molecules. And you see T3 is containing 3, T4 is containing 4. And you know that MIT and DIT, they are not thyroid hormones. Only T3 and T4, they are the thyroid hormones. But this MIT and DIT, they are also stored inside the thyroglobulin. So we have already discussed in the last class also how thyroid hormone is secreted. Okay, that means T3 and T4, they must be separated from the thyroglobulin molecule. Okay, with the help of iodinase. Okay, so here you see that this TSH, okay, thyroid stimulating hormone, after binding to this thyroid cell, to its receptors on the thyroid cell, it will lead to proteolysis of this thyroglobulin, so that T3 and T4 will be separated from the thyroglobulin molecule, and they can be secreted into the bloodstream. So T3 and T4 now they can reach the bloodstream. So this is one important function of the TSH. Okay, TSH. Okay, when we talk about TSH, okay, under anterior pituitary gland, I told you that it is stimulating the thyroid gland. Okay, how it stimulates the thyroid gland is that point number one is that it increases proteolysis of the thyroglobulin, so that there will be release of this T3 and T4 into the bloodstream. Okay, so this is taking place. What? Again. Okay. I think now okay. Okay, proteolysis. This proteolysis is taking place, as you can see from the diagram, in the thyroglobulin that has already been stored in the follicles. The proteolysis results in the release of the thyroid hormones, that is T3 and T4, into the circulating blood. This then leads to diminishment of the follicular substance itself. Okay, because of this release of the thyroid hormones, okay, the content of the follicle, it will be decreased. Sometimes, as you know, some thyroglobulin, they are also released into the bloodstream, but to a very lesser extent. Okay, so this is an important point. Okay, you have to remember that the first function of TSH is to increase proteolysis of the thyroglobulin, so that T3 and T4, they are released into the bloodstream. Okay, what is the point number 2? TSH function. Okay, it increases activity of the iodide pump. Iodide pump also we have already discussed. Okay, iodide pump also we have discussed. Okay, it means trapping of the iodine from the bloodstream. So let's say this is the capillaries, which is running through the thyroid gland. Okay, and here you see this is the follicular cell. On the basal side, you can see that sodium iodine symporter is there, okay, which will transport iodine along with sodium to the inside of the cell. Okay, so TSH, you know, TSH will increase the activity of this iodide pump. Okay, so that more iodine will enter the cell. That means more iodine will be trapped inside the follicular cells. Okay, you see, sometimes the increase in the ratio of, okay, the increase in the ratio of intracellular to extracellular iodide in the glandular substance may be as much as 8 times normal. That means the inside of this cell, okay, it will be having higher concentration. Still, they are not yet joining. Okay, I think it's okay. Okay. Okay, so the ratio may be 8 times normal. Here, the concentration of iodide, okay, it may be 8 times higher than that of this blood. Let's say here it is only 1, and inside it will be the concentration will be 8. Okay, so this increased activity of sodium iodide symporter, okay, is because of the activity of TSH. Okay, TSH will increase the activity of the iodide pump so that more amount of iodide will be trapped inside the follicular cells. Okay, more iodide trapping means more synthesis of the thyroid hormones. Okay, the first function was proteolysis of thyroglobulin. Number 2 is to increase the iodide pump for more synthesis of thyroid hormones. Okay, what is the third function of TSH? Okay, it increases iodination of tyrosine inside the thyroglobulin. Okay, so you see, okay, let's see this diagram. Okay, now iodide is entering the cell, and this has to be transported into the colloid. Okay, colloid of the follicle. So iodide is entering now the colloid, okay, through the apical membrane of this thyroid cells, through the pendrin channel, pendrin protein molecule here, which is present here in this cell membrane. And you know that inside the colloid, okay, this iodide form, it will be converted into oxidized form. That one also we have already discussed. Okay, it should be in oxidized form so that it will combine with the tyrosine in the thyroglobulin. So here you can see here iodination. Okay, it increases iodination of tyrosine means combination of iodine with tyrosine inside the thyroglobulin is also enhanced by the TSH. Okay, so this is the third function of the TSH. Okay, so it will increase more combination of iodine with tyrosine. So ultimately, it will lead to more formation of the T3 and T4. Ultimately, the function will be, the ultimate result will be more synthesis of T3 and T4 or thyroid hormones. Okay, what is the fourth function? Again, this TSH is having so many functions, okay, in the thyroid cells. TSH increases the size and increase secretory activity of the thyroid cells. Okay, so it will be increasing the size of the cells. Okay, hypertrophy will take place. Okay, which will increase the secretory activity also. What is the next function? So it will increase the number of thyroid cells also. Here you can see follicular cell. Okay, there will be increase in the number, that is hyperplasia. Increase in the number means more synthesis of thyroid hormones can take place. And the next one is it will convert cuboidal cells to columnar cells, causing much infolding of the thyroid epithelium into the follicles. Okay, so converting or changing cuboidal cells to columnar cells of these follicular cells, okay, will lead to more infolding of the thyroid epithelium into the follicles. That means there are more chances of synthesizing T3 and T4. Okay, so here you can see there are so many functions. Okay, when we talk about TSH, when we discuss about TSH, I just told you that it stimulates the thyroid gland. Okay, for the synthesis of T3 and T4 and their secretion. Okay, but now you know that how this is done. There are so many steps. Okay, which is influenced by the TSH. Okay, so we can summarize it like this: the function of TSH in the thyroid follicular cells. TSH increases all the non-secretory activities and synthesis of the thyroid glandular cells. That is regarding the thyroid hormones. Okay, we can say TSH increases all the secretory activities and synthesis for the thyroid hormones. Okay, T3 and T4. The most important early effect of administration of TSH is to initiate proteolysis of the thyroglobulin. So the first function of TSH, I've already told you, it is the proteolysis of the thyroglobulin. Okay, that is separation of, we can say, T3 and T4. So this is important because this will happen within 30 minutes. Okay, suppose you are injecting TSH, okay, thyroid stimulating hormones. Okay, the first effect of TSH you can observe is the proteolysis of the thyroglobulin. Okay, it is quite quick. Within 30 minutes, you can get that result. That means T3 and T4 will start appearing in the plasma, okay, within 30 minutes. But you see, the other effects require hours or even days or weeks to develop, okay? Like synthesis of the thyroid hormone, okay? All those things, it may take hours or even days or weeks, like trapping of the iodide, okay? Iodination of the thyroglobulin, that means combination of tyrosine and oxidized form of iodine. Okay, all those things, it will take longer time. It may take hours, even days or weeks. But regarding the proteolysis of thyroglobulin, within 30 minutes, you can get this result. Okay. Now let's see how TSH action is mediated. Okay. Cyclic AMP or CMP mediates the stimulatory effect of the TSH. Okay. Let us now go deeper. Okay, this one we have already discussed when we talk about the general mechanism of hormone action. Okay, here I'll just tell you once again. Okay, actually this diagram, it may not be just exactly correct. Okay, I did some addition here. Okay, so let's see. You know that cyclic AMP is a second messenger. Okay, second messenger also you already know. I think we have discussed a lot. Okay, cyclic AMPs, they are calcium calmodulin. They are also the second messenger. You know. Okay, so most, if not all, of the effects of TSH result from activation of second messenger, known as cyclic adenosine monophosphate system, CAMP. Okay, system. Okay, this you already know. Let's see. Okay, so this is the cell membrane. Okay, so this whole structure is the cell membrane, and here TSH receptor is there. TSH receptor is there, and this is facing the extracellular fluid, and this is facing the intracellular fluid. Okay, so when, let's say, this is the TSH. TSH is released from the, let's say, anterior pituitary gland, and then now it is binding to its receptors, okay, which is facing the extracellular fluid. When there is binding of the TSH, okay, there will be activation, okay, activation of these receptors. And you know that this one, I've already told you, okay, what it will do is that it will activate the G protein, that is stimulatory, okay, GS protein, okay. Here, you know, G protein, it is 3 subunits under alpha, beta, and gamma. That one also we have already discussed. Okay. Then this, when this is activated, alpha part, it will get detached from the whole unit, and it will activate adenyl cyclase. So this is a protein molecule, adenyl cyclase. Okay. So when there is activation of the adenyl cyclase, okay, adenyl cyclase, activated adenyl cyclase then convert ATP into cyclic AMP. Okay, and what cyclic AMP will do is that it will activate protein kinase. Okay, activation of protein kinase will be there. This is the enzyme, and protein kinase will cause, activated protein kinase will lead to phosphorylation of different types of enzyme inside the cell. Okay, when those enzymes are activated because of phosphorylation, what they will do is that increase synthesis and secretion of T3 and T4. Okay, so this is at the molecular level how TSH works. Okay, TSH, it just do the binding to its receptor, and the rest will be accomplished by the cyclic AMP. This second messenger will accomplish this thing. So the ultimate effect will be T3 and T4 synthesis, increased T3 and T4 synthesis, as well as increased secretion of these hormones. Okay. So I'll not repeat here. Followed or not this part?
Yes, sir.
You understood? Okay. Actually, this one, it was already discussed when we talk about the general mechanism of hormone action. Okay, that second messenger system we'll discuss. Just here, I just want to highlight how this TSH is doing using that mechanism. Okay. So what about the regulation of TSH secretion? This one also we have already discussed when we talk about TSH. Actually, it is not exactly TSH secretion. Let me just add this one. Because these are all interrelated, and TSH and thyroid hormones, their regulation, we cannot separate them. Okay, they are all interrelated. Okay, let's see. This one you know very well already, I think. Anterior pituitary secretion of TSH is controlled by the hypothalamic hormone thyrotropin releasing hormones. Okay, TRH is there. Okay, this we have discussed. TRH in the anterior pituitary gland. It stimulates the secretion of the TSH. Let us go like this. Then TRH. Okay, I'll not repeat this one. When the portal system, that hypothalamic hypophyseal portal system also we have already discussed. Okay, bloodstream, network of blood vessel, that will the primary plexus, secondary plexus, all those things we have already discussed. Okay, when the blood portal system from the hypothalamus to the anterior pituitary gland becomes blocked, the rate of secretion of TSH by the anterior pituitary decreases greatly, but is not reduced to zero. Okay, so suppose there is blockage here. Okay, from the hypothalamus to the pituitary gland. Okay, if there is no communication between this one, blood vessels, suppose they are blocked. Okay, so TRH will not be available to stimulate the anterior pituitary gland for the production of TSH. So ultimately, the production of TSH will be reduced greatly. Okay, but here it says it is not zero, not reduced to zero, but ultimately significantly or greatly affecting the TSH synthesis and secretion. Okay. But increased thyroid hormone in, let's say, increased thyroid hormone in the body fluid decreases secretion of TSH from the anterior pituitary gland because of that I've already told you, negative feedback mechanism. Suppose TSH is stimulating thyroid gland. Okay, secreting, synthesizing, and secreting T3 and T4. But when the level of these thyroid hormones, T3 and T4, when they are going up and when it is reaching the maximal level, what will happen is that it will have a negative feedback. Okay, all these things we have already discussed. Okay, when the rate of thyroid hormone secretion rises to about 1.7 times normal, the rate of TSH secretion falls essentially to zero. Okay, so when thyroid hormone secretion has risen to 1.75 times, the secretion of TSH will be blocked or will be zero. Okay, almost all these feedback depression effect occur even when the anterior pituitary has been separated from the hypothalamus. That means suppose you cut here hypothalamus at junction link between hypothalamus and pituitary gland. Suppose you cut it. Okay, still this is suppression is taking place. Okay, means TSH secretion will be zero or reduced to almost to zero. Okay, that means you can say that therefore it is probable that increased thyroid hormone inhibits anterior pituitary secretion of TSH mainly by a direct effect on the anterior pituitary gland itself. That means here we can see that suppose that you cut it, okay, link between hypothalamus and pituitary gland. That means this negative feedback will not be available. TRH, okay, suppression will not be available, but only direct effect on the pituitary gland through decreased TSH is there. Okay, it means this direct effect. Okay, this is the direct effect on the pituitary gland by increased thyroid hormones. Okay, so this is very, very effective in suppressing the secretion of the TSH. Okay, regardless of the mechanism of the feedback, its effect is to maintain an almost constant concentration of free thyroid hormones in the circulating body fluids. Okay, so we have to remember that we are here to discuss the physiological aspect, not the pathological aspect here. Okay, it means that when there is increase in the thyroid hormone secretion, okay, when it is moving above the maximal normal level, okay, so there will be starting of negative feedback action on the hypothalamus to decrease DRH secretion, as well as on the pituitary gland to decrease TSH secretion, so that the level of this TSH will also go down, and then its effect on the thyroid gland will also be reduced, and thyroid hormone concentration will also go down. Okay, but as I've already told you earlier, when it is going below the normal level, okay, this negative feedback mechanism will be stopped, so that more TRH and more TSH, and ultimately more thyroid hormones will be produced again. Okay. So mechanism of TSH secretion, how they are secreted. Okay, that earlier I've already told you another way how this is sorry, this is the okay, this is another mechanism of TSH secretion. Okay, so this is, as you know, it is influenced by again the TRH. Okay, we'll just discuss it. Earlier I've already told you that cyclic AMP. Okay, so this is how TRH, okay, is acting on its receptor in the anterior pituitary gland. Okay, so the previous one was about the TSH acting on its receptor in the anterior pituitary in the thyroid gland. Okay, so this is regarding the TRH. So here, this is the receptor of the TRH. Okay, it binds here, and what will happen is that it will also stimulate the G protein which is present in the cell membrane. And this activated G protein, then it will activate phospholipase C. Okay, then what is the function of this phospholipase C? It will convert PIP2. Okay, phosphatidyl inositol diphosphate. Okay, it will convert this one into IP3 inositol triphosphate and diacylglycerol. Okay, and this DAG and IP3 then enter the inside of the cell. What is the function of this DAG? It will activate inactive protein kinase C through activated protein kinase C. And this, when this enzyme system is activated, it will cause phosphorylation of many enzymes again. Okay, when there is phosphorylation of that enzyme, increased activity of the enzyme for the synthesis of TSH will be there. So another function of IP3, the function of IP3 inositol triphosphate is it will lead to a release of calcium from the endoplasmic reticulum, and this calcium, this both phosphorylation of the enzyme as well as this calcium, what they will do is that increase synthesis and release of the TSH. When there is increased synthesis and release of TSH, you already know that in the previous slide we talked about how TSH is acting on the thyroid cells. Okay, then ultimately there will be increased formation of T3 and T4 and their secretion into the bloodstream. Okay, so what about the next topic? It is effects of cold and other neurogenic stimuli on TRH and TSH secretion. Okay, so let's see. One of the best known stimuli for increasing the rate of TRH secretion by the hypothalamus and therefore TSH secretion by the anterior pituitary gland is exposure of an animal to cold. That means suppose you are exposing an animal or yourself to cold environment. Okay, there will be increase in the TRH secretion, which will ultimately lead to increased TSH secretion. And when there is increased TSH secretion, there will be increased formation and release of T3 and T4. Okay. This effect almost certainly results from excitation of the hypothalamic centers for body temperature control. Okay, so this is important. This is almost indirect effect we can say, not on the anterior pituitary gland, but on the hypothalamus to produce more TRH. Okay, because hypothalamus is the center for temperature regulation of our body. Okay, a person moving to Arctic regions has been known to develop BMR 15 to 20% above normal. Okay, suppose here in India, India is very hot, you can say. Suppose you are moving to the Arctic region. Okay, so your TRH secretion will be increased. Okay, because you are exposed to that cold environment, and you may develop increased BMR, which may be 15 to 20% above normal. Because there is increased TRH secretion, that means TSH secretion will also be increased, and there will be more formation of T3 and T4. Okay. Another point is that this is neurological. Okay. Various emotional reactions can also affect the TRH and TSH. Okay, and therefore indirectly affect the secretion of thyroid hormones. Okay, emotional states, different types of emotional states. Okay, they are also influencing the formation of TRH and TSH, and ultimately T3 and T4. Okay, for example, excitement and anxiety. Okay, conditions that greatly stimulate the sympathetic nervous system cause the acute decrease in the secretion of TSH. Okay, suppose if you are excited or if you are having some anxiety, okay, your sympathetic nervous system will be stimulated, and that will decrease the secretion of TSH. That means secretion of TSH decrease means T3 and T4 formation and release will also be decreased. Okay, perhaps because these states increase the metabolic rate. So we all know that when you are excited or when you are having some fear or nervousness, okay, your body temperature will decrease or increase. Can any one of you tell me when you are excited or having anxiety or having nervousness? What do you feel? Your body feel hotter or colder? Any of you?
Cold, sir. Cold.
Huh? It will become cold or
Cold,
hot.
sir.
It will become hot now because you start sweating also. You feel somewhat hot. So that is because your BMR has increased. Okay, your BMR has increased, so you start sweating. So it depends upon the person. Okay, some people they may not have that much problem, but in others it may be very obvious also. Okay, so metabolic rate will be increased, BMR will be increased. Okay, when there is increase in the BMR, okay, it will have inverse effect on the heat control center in the hypothalamus. Okay, then what will happen is that there will be suppression of TSH secretion or TRH secretion. Oh, sorry, TRH secretion will be suppressed because the body is already hot. BMR is already high. Okay, or we can say your metabolic rate is already high. So there is no need of more formation of T3 and T4 because body is already having very high metabolic rate. Okay, so there will be a negative feedback on the hypothalamus to decrease TRH. Okay, so that the body will cool down. Okay, neither these emotional effects nor the effects of cold is observed after the pituitary stalk has been cut, demonstrating both of these effects are mediated by way of hypothalamus. Okay, now this is just the opposite of what we have discussed in the last slide. Okay, so hypothalamus is very important regarding this control. Okay, if you cut the pituitary stalk or hypophyseal stalk, okay, this condition will not be observed because TRH is controlling this emotional reactions like excitement, anxiety. Okay, to decrease, what to say, T3 and T4 secretion. Okay, now next is the diseases of the thyroid. We have almost finished. Okay, here we will not finish this topic, so half we will discuss today. Okay, diseases of the thyroid. Okay, let's see the hyperthyroidism. Hyper means above normal. Okay, here excessive production of thyroid hormones by the thyroid gland. Okay, we can say it is a condition when there is excessive production of thyroid hormones by the thyroid gland. Okay, that is hyperthyroidism. In most cases, the thyroid gland is increased to 2 to 3 times normal size. Okay, usually when there is hyperthyroidism, okay, there will be increase in the size of the thyroid gland. Okay, there are tremendous hyperplasia that I've already told you. Hyperplasia means increase in those cells, follicular cells, and infolding of the follicular cell linings, okay, in the follicle, so that the number of cells is increased greatly. Okay, that means it will lead to more production of excessive production of thyroid hormones. Okay, each cell also increases its rate of secretions several fold. Okay, so here we can see two conditions. Number one is more synthesis of the thyroid hormones. Okay, and there is also increase in its secretion. Okay, hyperplastic glands secrete thyroid hormones at a rate 5 to 10 times normal. Okay, under hyperthyroidism or in a condition of this hyperthyroidism, the secretory rate is very high. That means it may range from 5 to 10 times normal. So plasma TSH concentration are less than normal rather than enhanced in almost all patients, and are often essentially zero. Okay, so plasma thyroid stimulating hormone concentration are less than normal. Actually, under normal condition, it should be more, because more TSH will lead to more production of the T3 and T4. Okay, but this is not the case in almost all patients. Okay, that we'll discuss why this is happening. Okay, however, other substances that have action similar to those of TSH are found in the blood of almost all these patients. So this point is very important. Okay, in almost all cases of hyperthyroidism, plasma concentration is less than normal. It may be zero also. Okay, but we have to remember that in this condition, in hyperthyroidism, most of the time, substances that have actions similar to those of the TSH are found in the blood. Okay, here you see in almost all these patients. Okay, these substances are immunoglobulins. Okay, these are immunoglobulins, so immune system is involved, that bind with the same membrane receptor that bind TSH. Okay, in the previous slide, we talked about how TSH bind to each receptor and activating all this cyclic AMP we have discussed. Okay, in hyperthyroidism, this is a pathological condition, and instead of TSH, okay, immunoglobulins, okay, are activated, which can bind to the same receptor. Okay, that means TSH receptors. Okay, so you know these immunoglobulins, which are known as TSI, okay, they induce continual activation of cyclic AMP system of the cells, with resultant development of hyperthyroidism. So you know that increased cyclic AMP concentration, it is leading to more synthesis of T3 and T4 and increased rate of secretion that we have already discussed. Okay, now these antibodies, okay, or immunoglobulins, okay, they are called thyroid stimulating immunoglobulin, designated as TSI. So we have TSH, thyroid stimulating hormone, coming from the anterior pituitary gland. Okay, and in hyperthyroidism, immunoglobulins known as thyroid stimulating immunoglobulin is produced in large amount. Okay, and you know that this TSI or thyroid stimulating immunoglobulin, they can bind to the TSH receptor. Okay, so in almost all cases of hyperthyroidism, so this is the case. Instead of TSH binding to its receptor, there will be TSI. Okay, TSI will bind to TSH receptor, so that it will stimulate production of T3 and T4 to a great extent. That is why in hyperthyroidism, most of the time, TSH concentration is very less. Okay, it may be zero also, as I told you. Okay, But under normal condition, this TSH and thyroid hormones, they are interrelated. Okay, increased TSH is very important for the synthesis of T3 and T4. Okay, but in hyperthyroidism, this is not the case. Okay, in most cases. Okay, so this TSI, they have a prolonged stimulatory effect on the thyroid gland, lasting as long as 12 hours, in contrast to little over 1 hour for TSH. So TSH, their duration of action is very long, 12 hours. TSH is only 1 hour. Okay. The high level of thyroid hormone secretion caused by TSI in turn suppresses anterior pituitary formation of TSH. So now this is why there is decreased TSH. Okay, because TSH has increased, and when its duration of action is also very long. Okay, so this TSH will suppress secretion of TSH from the anterior pituitary gland. Okay. The antibodies that cause hyperthyroidism almost certainly occur as a result of autoimmunity that has developed against thyroid hormone. Now, this point is very important. Why TSI is produced? TSI, they are immunoglobulins, or we can say antibodies. Immunoglobulins and antibodies, they are same thing. Okay, this TSI, okay, they are produced due to autoimmunity that has developed against thyroid tissue. Okay, autoimmunity means suppose your body, when foreign body enters your body, okay, so they will attack that foreign bodies. For example, virus infection or bacteria, you have viral or bacterial infection. Okay, infection is there. So when those microorganisms enters your body, okay, they are recognized as foreign particle. So because of that, antibodies will be produced to attack those foreign particles or microorganisms. Okay, so here in case of hyperthyroidism, there is autoimmunity. Autoimmunity means the body is producing some antigen, okay, some antigen which is acting against its own cell. Okay, autoimmunity. For example, SLE. SLE, I don't know what is the full form. Any of you know what is SLE disease? Have you heard about SLE? Oh, so this SLE is also very common among women. Okay, so here also there is autoimmunity is there. Okay, certain antigens is produced by the body itself, and it start attacking or destroying the tissue. Okay, that is why immunity will go down. Okay, so that means the molecules which is inherent to the body, okay, they are attacking the other tissues. Okay, that can happen. Okay, that is autoimmune disease also. It is under the autoimmune disease. Okay, so in case of hyperthyroidism also, most of the time, this is the condition. Autoimmunity is there against the thyroid tissue. Okay, presumably at some time in the history of the person, an excess of thyroid cells antigen was released from the thyroid cells. Okay, this has resulted in the formation of antibodies against the thyroid gland itself. So you see that these thyroid cell antigens, okay, molecules, they are produced, okay, due to some reason, and this will lead to production of antibodies, and these antibodies will act against the gland itself. Okay, and this is, we can say here in this example, TSI is there. Okay, hyperthyroidism occasionally results from, that is the first cause. Okay, the first cause of hyperthyroidism is the that one, autoimmunity. Okay, TSI is produced. Okay, TSI will lead to, it will stimulate the thyroid gland for production of T3 and T4. Okay, so occasionally another cause of hyperthyroidism may be localized edema of the thyroid gland. Suppose this, let's say this is a thyroid gland. Okay, H-shaped thyroid gland. So suppose there is localized adenoma. Okay, here tumor is induced here. Okay, So tumor of a localized area of the thyroid gland takes place. Let's say this is adenoma. Okay. It is not autoimmunity. Okay. The first autoimmunity, okay, it may be localized adenoma. And you see that this tumor, this part, okay, whenever there is tumor, that means there is increase in the cell number. All those follicular cell number will increase, okay, or maybe hypertrophy also, okay. Then they will start producing large amount of thyroid hormones. So it is clear, okay. Here adenoma is there, localized tumor, okay. Then this is different from the more usual type of hyperthyroidism in that it is usually not associated evidence of the autoimmune disease. This is not related to autoimmune disease as discussed earlier. An interesting effect of the localized adenoma is that as long as it continues to secrete large quantities of thyroid hormone, secretory function in the remainder of the thyroid gland is almost totally inhibited. Okay, so this point is important. Okay, so you see that when there is localized adenoma in the thyroid gland, okay, this will start producing thyroid hormone, and remainder of the thyroid gland, okay, other areas, all these areas, okay, they usually do not produce thyroid hormones, okay. Only this tumorous part will produce thyroid hormones, okay. Rest of the thyroid gland, they will remain as such, or they will not synthesize or secrete T3 and T4, okay. This is because the thyroid hormone from the adenoma depresses the production of TSH by the pituitary gland. So it is clear that here T3 and T4, they are produced. Okay, this T3, then there will be suppression on the pituitary gland or on the hypothalamus to decrease TRH and TSH production. Okay, so other areas of the thyroid gland, they will not be stimulated by the TSH. Okay, so what are the symptoms of hyperthyroidism? Symptoms of hyperthyroidism, number one, a high state of excitability, okay, nervousness. Number two, intolerance to heat. So you know that when there is increased T3 and T4, metabolic rate will be increased. As I told you, your body will become, hotter. Okay, heat production will be increased. So because of that, you will not be tolerant to heat. Increased sweating. It is clear that rate of metabolism is increased, body temperature increase, sweating will be increased. Mild to extreme weight loss. Okay, so catabolism has increased. Okay, breakdown of all these things is BMR is increased, catabolism is increased. So that will lead to catabolism of all those energy sources, maybe from the adipose tissue or some other tissues. Okay, so there will be mild to extreme weight loss depending upon the severity. Number five, varying degrees of diarrhea. Okay, it can lead to diarrhea. Okay, muscle weakness, nervousness, or other psychotic disorders. So I think this you might have observed in some people who are suffering from this hyperthyroidism. So you know that it is affecting our psychology also, okay, or our brain also, okay. Psychotic disorder may be observed, extreme fatigue but inability to sleep, okay, tremor of the hands, exophthalmos, okay, that is the protrusion of the eyeball. I think this is not observed in all the patients, but many people or many patients, they are suffering from this protrusion of the eyeball. I think we have observed this patients, okay, in your relative or your friends or whatever, whoever you're close to, that these people, there can be protrusion of the eyeball. This is because of the hyperthyroidism. Okay. What are the diagnostic tests for hyperthyroidism? Actually, these are all pathological conditions, but it may come in your exam also. Okay, we have to know this one. So nowadays, thyroid function test, it is very common. Okay, we just call this a thyroid test. Okay, TSH and thyroxine levels are usually determined. So most accurate diagnostic test is measurement of the concentration of free thyroxine. Only we have to measure the free thyroxine. Okay, so most of them, more than 99%, they are bound to the plasma protein. Okay, you already know that one. So the concentration of free thyroxine has to be determined. Sometimes we may also determine the T3 then by the process of radial immunoassay. Okay, so this is the most accurate diagnostic test for the hyperthyroidism. Other tests includes measurement of the BMR, basal metabolic rate. In case of severe hyperthyroidism, as you know that there may be increase in 30 to 60% in the BMR. Okay, and another test can be employed is determination of concentration of TSH in the plasma, again by radioimmunoassay. Okay, so as I told you, TSH value will be very low. Okay, maybe zero also. Okay, in usual type of thyroid toxicosis. That the usual type of thyroid toxicosis is, as I told you, it is autoimmune reaction due to autoimmune reaction. Okay, so in this condition, anterior pituitary secretion of TSH is so completely suppressed by large amount of circulating thyroxine and T3 that there is almost no plasma TSH. So plasma TSH will be very low. Okay, but here in the first test, okay, for example, T4 value will be very high because it is hyperthyroidism. Okay, another test we can do is determination of concentration of thyroid stimulating immunoglobulin, again by radioimmunoassay. Okay, so usually TSI should not be there if there is no autoimmune reaction. Okay, but if there is increasing concentration of the TSI, we can say that there is that hyperthyroidism, that is thyroid toxicosis, which is due to autoimmune reaction. But in case of thyroid adenoma, TSI is very low. Okay, what about treatment in hyperthyroidism? Most direct treatment is surgical removal of most of the thyroid gland. Okay, so we know that usually in case of severe cases, surgery is necessary. Okay, we have to remove the thyroid gland. It is desirable to prepare the patient for surgical removal of the gland before operation. Actually, these are all clinical part. Okay, what we have to do is that before removal of the thyroid gland, okay, patient has to be prepared. Means this can be done by administering propyl thiouracil. Okay, this will block the peroxidase for oxidation of iodine. That it will decrease the oxidized form of iodine. Okay, this propyl thiouracil, it will block this peroxidase. Peroxidase is important for, as you know, oxidation of the iodine from the iodide form that we have already discussed. Okay, this can be done usually for several weeks until the BMR of the patient has returned to normal. Okay, then after this, after blocking peroxidase, then administration of high concentration of iodides. Okay, we are blocking the iodine, means oxidized form of iodine. But after that, you have to administer high concentration of the iodides for 1 to 2 weeks immediately before operation, which causes the gland itself to recede in size and its blood supply to diminish. So this is important. The gland will decrease in size and blood supply will also be decreased. So that is important for preventing blood loss during operation. Okay, by using this preoperative procedure, that means preparing the patient before operation, the operative mortality is less than 1 in 1,000 in the better hospital, whereas before development of modern procedures, operative mortality was 1 in 25. So preparing that patient is very important for surgery like this, okay, which will minimize the death of the patient. Okay, so this for today. In the next class, we'll discuss about the hypothyroidism. Okay, thank you. Have a good day.
Thank you,
Thank
sir.
you, sir. Thank you, sir.
Thank you, sir.
Thank you, sir.